Hi, this is Jeff Klein, editor of RadioGraphics, and today I'm pleased to have with us Dr. Myra Feldman from the Department of Radiology at the Cleveland Clinic Foundation in Cleveland, Ohio, who is the first author of one of our featured papers in the current January 2020 issue of RadioGraphics. And her article is entitled New Frontier, the Role of the Radiologist in Uterine Transplantation. Dr. Feldman, welcome to one of our January 2020 author podcasts.
Thank you, Jeff. I'm excited to be here and have this opportunity to talk with you and your listeners about uterus transplantation.
Great. Well, thanks so much, and thanks for the paper. So, Myra, this is a really fascinating article which describes a new experimental surgical procedure that's being performed at a select number of institutions around the world for uterine-related infertility, which is termed absolute uterine factor infertility. Can you tell us how the procedure came to be performed at the Cleveland Clinic and how you and your colleagues in radiology became involved in this particular initiative?
Sure. So the way that uterus transplantation came to the Cleveland Clinic actually started with one of the co-authors of this paper, Dr. Andy Tsakis. Dr. Tsakis is a transplant surgeon and a bit of an innovative pioneer within the field of transplantation. He was really interested in uterine transplantation from the inception of the field. In fact, he traveled to Sweden to learn from the team that pioneered research in uterus transplantation. After the success of the Swedish team, he came back to the States and sort of organized our protocol, our team, and got it up and running at our institution. I think our institution was really a perfect place to launch such an ambitious project. We are a large transplant center, and we do have a lot of the expertise, both from the physician side and also from the allied medical health professional side, that is required to support such a project. Our second point about how radiology came to be involved in the project, we actually were not involved formally from the outset of the project. After the first transplant was performed at our center, the team did run into some difficulty with that transplant and required a lot of high-level imaging to sort of sort through those complications. And that's when I think that experience really opened their eyes to the importance of having a radiologist as a more formal member of their team. And I sort of wound up being that person. It made sense for me from a couple different perspectives. I was very interested in it. I'm also the medical director of ultrasound at our hospital, so that was important in sort of coordinating with our sonographers, and I also have an interest in female pelvic imaging. So I think it's helpful to have a champion from the radiology side just to help navigate the complexity of a radiology department.
Yeah, no, absolutely. I mean, your relationship obviously with them on the imaging side must have been crucial to the development of this particular relationship. So, Dr. Feldman, your article begins with the definition of absolute uterine factor infertility and the common causes for this particular condition. Can you tell our listeners how absolute uterine factor infertility is defined and review some of the common causes?
Sure. So this was something I actually didn't know much about before I became involved in this project. I'm actually going to take one step back and first talk about uterine factor infertility, define that. So uterine factor infertility is a term used to describe any abnormality of the uterus that can be linked to subfertility or infertility. And causes of that would be things like submucosal fibroids or endometrial polyps, as well as some of the congenital Mullerian abnormalities like bicornuate uterus or septate uterus. Women with uterine factor infertility have a uterine abnormality that may make it difficult for them to conceive or to carry a pregnancy, but carrying a pregnancy is still possible. Absolute uterine factor infertility is a different story, and that is the population that uterus transplantation aims to treat. So absolute uterine factor infertility is caused when women have a non-functioning uterus or an absent uterus. Causes of absolute uterine factor infertility can be divided into two groups. One would be congenital and the other acquired. So the most common congenital cause is Myra-Rokitansky-Kuster-Hauser syndrome, which I'm going to refer to as MRKH for the rest of this podcast. So this is a syndrome that affects about 1 in every 4,500 women, and it's characterized by marked hypoplasia of the uterus as well as upper third of the vagina. Some women with the syndrome do have rudimentary uterine tissue, but it's small and it could never support a normal pregnancy. In terms of acquired causes of absolute uterine factor infertility, the main cause would be hysterectomy. And there are a number of reasons why women of childbearing age would have a hysterectomy. One would be malignancy, so cervical cancers or endometrial cancers. Sometimes women have to have hysterectomies to treat severe bleeding, post-obstetrical bleeding, or bleeding from other causes like fibroids or endometriosis. And then finally, sometimes women can have very just damaged uterus from infection, trauma, radiation, or even iatrogenic injury as a cause.
Great. So Myra, the article then proceeds to discuss some of the ethical issues surrounding uterine transplantation, which I would imagine are not insignificant, and then goes on to provide a historical timeline of uterine transplantation. Can you take us through the history of this procedure and perhaps give us a sense of whether this procedure will grow in years to come, in your opinion, or is this something that's more likely to be a procedure that's going to be limited to a very small number of specialized centers?
Okay, sure. So uterus transplantation, interestingly, first started decades ago in the 1960s with a canine model. In the years that followed that, there were a couple of isolated reports of uterine transplantation in human models, but the field really took off thanks to Mats Brandstrom and Michael Olason and their team from Sweden that really pioneered the field, first with over a decade of research in animal models before moving on to their human uterine transplant cohort, which they did with living donors. And the Swedish team did report the first successful live birth from a uterine transplant in 2014. Since that time, there are now a number of institutions across the world that have research protocols up and running and at various forms. It's hard to know exactly how many uterus transplants have been performed at this time and how many live births have been performed. In the paper, I said that there have been 30 transplants and 10 live births. I was reporting things that have been published in the medical literature, and we know based on what's out there in the in the media that the numbers are actually larger than that. So I do think that the number of transplants will continue to grow. I think there's a large interest across the world in this. I do think this is also something that will naturally filter to larger academic centers that can support this kind of thing with the various levels of expertise that are required to support such a project.
Of course. So let's go on and talk about recipient selection, in particular the preoperative imaging evaluation. Can you discuss the imaging evaluation of potential uterine transplant recipients and also address why oocyte harvesting and in vitro fertilization is necessary?
Absolutely. So some of the workup from an imaging standpoint is similar to what patients undergoing other kinds of transplantations would undergo. Things like a chest x-ray or potentially an unenhanced CT if the patient is at risk for atherosclerotic calcifications. There are some imaging studies that would be more unique to this population. Many women need to undergo imaging, first of all, to confirm the diagnosis of absolute uterine factor infertility. That's typically done with ultrasound, but sometimes MRI is also required. With the congenital causes of absolute uterine factor infertility, there are associated anomalies, sometimes renal anomalies, as well as vascular anomalies. And sometimes we needed to use high-level imaging like CTA or MRA to sort of further delineate the anatomy for pre-surgical planning. One unique aspect of uterine transplantation is the fact that we do need to have oocyte harvest beforehand. The reason for that is that the fallopian tubes are not transplanted or they're not going to be connected to the patient's natural ovaries. So I think it's important to take a step back and remember that success in uterine transplantation is not defined when the transplant takes, okay? It's defined when there is a live birth at the end of this. So we're not only looking for women who are healthy enough from to undergo surgery or cleared from a medical, psychological, and social standpoint. We're also looking for women who have good ovarian reserve and good ovarian reproductive potential. And currently, all the trials that are up and running do require good quality frozen embryos prior to having patients enroll in the studies.
Great. So moving to donor selection, can you discuss the advantages and disadvantages of living versus cadaveric donors and review the imaging evaluation of donors at the Cleveland Clinic. And as you answer this, we'll take a look at Table 2, which lists the donor selection criteria for both living-related and cadaveric donors.
Sure. So this is a really interesting topic. The first transplants that were performed did use living donors. And there are a number of advantages with the living donor model. Number one, you get to know everything about the donor's medical history. It's a lot easier in terms of scheduling. And the ischemic time is reduced because you're moving just next door from the OR. The big disadvantage of living donors is there are risks associated with the procurement procedure, and they are not insignificant. So the procurement hysterectomy is not a simple hysterectomy. It's more akin to a radical hysterectomy. So this is a surgery that involves deep dissections in close proximity to vessels and ureters. It's a longer procedure with a longer anesthesia time. So these are all risks. When you think about transplants that are being done for life-saving measures like liver and kidney, it's a little bit easier to sort of accept these kinds of risks, and it's a little harder when you're dealing with something that's not a life-saving transplant. There's also social and potential emotional risks to these donors. Coercion is something we worry about, and potential for guilt if the transplant doesn't take or if the pregnancy doesn't take. So the risks of the live model are not insignificant. Deceased donors have the obvious advantage of completely eliminating all of that risk, okay? And another interesting potential advantage of the deceased model is that the vascular pedicles that are available are longer. So we can take part of the internal iliac artery, we can harvest that along with the uterus so that we have a larger anastomosis for both the arterial and venous anastomosis. And that's important because the number one problem that we've seen with the uterus transplants is with the vascular anastomosis failing. So that's a potential advantage as well. The main disadvantage, I would say at this time, well, one potential disadvantage would be that the ischemic times are longer, but the main disadvantage is that there is a scarcity of deceased donors available. And so if you look at the low numbers of deceased organ donors that are available for any organ donation program, eliminate all the men, eliminate all the women, and then, we turn to Table 2 and look at some of the other criteria that would cause someone to be eliminated, like a history of cervical dysplasia or HPV. We want to look for low risk donors, so people who've never, had IV drug use or don't have any infections like hepatitis. Women who have normal uteruses during their cadaveric imaging evaluation. And then all the other things that we have listed in this table, you wind up with a very small pool of potential donors. And so I think if we rely just on the deceased donor model, we would probably never be able to meet the demands for organ transplants.
Great. So Myra, regarding the surgical procedure itself, the article provides really beautiful renderings of the vascular and vaginal anastomoses for both cadaveric and living transplants. Which are in figures 5A and 6A in the article. For postoperative evaluation, you describe your protocol for ultrasound evaluation of the transplanted uterus, in particular the vascular portion of the exam. Table 3 in the article lists the protocol for the exam, but can we look at figures 8 and 9, which shows examples of the arterial and venous evaluation of the transplant?
Sure. So one thing I'm going to say is our institution, we used only the deceased donor model. So all of our anastomoses were between the donor internal iliac artery and vein and recipient external iliac artery and vein. So it was a much larger caliber anastomosis that we were looking for. And we modeled our protocol after renal transplant protocol here. You can tell by the images in figure 8A that we used transabdominal technique for our studies. We found we were able to see definitely the external iliac anastomosis. I don't think we'd be able to see that by transvaginal technique, but we were able to see everything by transabdominal technique. That worked out well for us. So our studies, we would start by evaluation of the external iliac artery, and evaluate for patency, make sure there's no dissection, and identify the location of the anastomosis. And that's what we're showing you here in figure A. The white arrow is pointing to the donor internal iliac artery as it comes off of the adjacent external iliac artery of the recipient. We would then follow the internal iliac artery to the uterine artery. And sometimes it was difficult to see it all the way down to the lower uterine segment where it inserts into the uterus. So sometimes we would just skip down to the lower uterine segment, which is what we're showing here in figure B. And if you take a look at that spectral waveform, it's really what you would expect to see. There's a brisk upstroke and there is antegrade flow throughout diastole. So a normal uterine artery waveform at the lower uterine segment. The final part of our exam would be to evaluate the intraparenchymal arteries. Our transplant surgeons were very interested to know that we could detect arterial flow within the transplant itself, and so that's what we're showing you in figure C. We would do that at the fundus sort of mid segments and then also at the lower uterine segment. If I skip down to figure 9, now we're doing the venous portion of our exam, and very similar to the arterial portion, we would start with the external iliac veins and find the origin of the anastomosis with the internal iliac vein, and that's what we're showing you here in figure 9A with the white arrow pointing to the donor internal iliac vein. The veins are very small caliber with pretty slow flow, so they could be almost impossible to follow all the way down to the lower uterine segment. So in the case of the veins, we would then just skip right down to the lower uterine segment and look for venous flow external to the uterine parenchyma at that location. And that's what we're showing here in figure B. And then just like with the arteries, the transplant surgeons were very interested to know if we could detect intraparenchymal venous flow. This was pretty tricky because, as you can see here, the velocity is 7 centimeters per second. That was typically what we found, very slow velocities, less than 10 centimeters per second. But we were able to detect it, and we would look sort of fundal, mid, lower segment, and then do that bilaterally.
Terrific. So, Myra, in the final section of the paper, you discuss embryo transfer and pregnancy. You're right that there are no standards for fetal imaging in pregnancy following uterine transplantation beyond those of routine obstetrical practice. Anything else that should be considered in the imaging evaluation of these particular pregnancies?
Well, I think at this point, the world experience with pregnancy in uterine transplant lags behind our experience with the transplant procedure itself. And there are a number of reasons why that's the case. So number one is graft failure. Not all the transplants that are performed take. A second reason is that most of the protocols that are up and running across the globe use some sort of a lag period between the time when the uterus transplantation surgery is performed and when embryo transfer is attempted. It's usually between 6 months to 1 year. And that's really just so that we can establish stable anti-rejection regimen before introducing a variable like pregnancy to the equation. Another reason why there's such a lag is that there is inherent complexity to the process of implantation and establishment of a viable pregnancy after embryo transfer. So not every transfer that's attempted will take. And then, of course, finally, the length of human gestation. I think the largest experience that has been described at this point is with the Swedish team. And, they have reported problems with preeclampsia and cholestasis in some of their pregnancies. So at this point, I think we're treating the pregnancies like normal pregnancies from an imaging standpoint. It's probably too early to know if there's anything out of the ordinary that we need to be looking out for with these pregnancies.
Terrific. Well, Dr. Feldman, I want to thank you for taking the time today to discuss your really fascinating paper on the imaging of uterine transplantation, which is found in our current January 2020 issue of Radiographics. Thanks so much for taking the time today.
Thank you, Jeff.